Ken Landau. Thanks for watching. Let's talk about cataracts. Cataracts come from the Latin word meaning waterfall. Cataracts involve the lens of the eye. The lens sits behind the pupil and right in front of the vitreous body, which itself sits in front of the retina. Now, the cataract under normal circumstances is transparent and it's a biconcave structure. Helps refract light onto the retina. It's composed of water and protein and thin fibers that are surrounded by a tiny capsule, and the capsule itself is held in place by strands of fibrous tissue we call zonules that are attached to the ciliary muscle. Well, in this year, we expect about 4 million cataracts to be removed surgically here in the United States. And we don't think much of cataracts. You could develop cataract, go see the doctor, get taken out. But in the world, cataracts are responsible for about 20 million people being blind, especially in the low-income and the middle-income countries. Estimated they cause as much as a third of visual impairment worldwide, so cataracts are still very important. We call them age-related cataracts for the most part because they tend to develop as we get older. And unfortunately, getting older starts at about age 40. So they're not symptomatic, however, until you get to be about age 60. Then once you get age 60, then you start having some of the problems. So about 40% of the population notices problems associated with cataracts at about age 60, about 60% of the population at age 70, about 90% of the population about age 80, with different degrees of involvement of one eye versus the other. Seems that women are at greater risk than men. Seems that whites are at more risk than blacks and Hispanics. We can divide or categorize cataracts into a variety of different groups. So one of the very common ones is just age-related cataracts and pediatric cataracts, and then cataracts caused by other causes. Well, if we talk about age-related cataracts, they're by far the most common. They tend to begin somewhere between age 40 and 50. Caused by oxidative stress. That leads to opacification of those proteins. Something happens to those proteins, and we get denaturing of the proteins, just like the egg white. So the egg white starts off clear, the albumin, that's high protein content. That's high protein content inside your eye, but exposed to heat and exposed to oxygen, turns opaque and white. That's what happens. So 3 types of age-related cataracts. We have the nuclear cataract, the cortical cataract, and the posterior subcapsular cataract. Risk factors: age, of course, female sex, lower socioeconomic status, lifestyle, people who drink alcohol, smoke cigarettes, those people are at increased risk. Diet can put you at increased risk. If your diet has a lot of carbohydrates, especially carbohydrates that have high glycemic index, that puts you at greater risk. If you're malnourished, that also puts you at greater risk. Medical diseases can put you at increased risk. So type 2 diabetes, it's a very common cause of cataracts. Renal impairment, low serum calcium, also hypertension, and a condition called the metabolic syndrome. And the metabolic syndrome is basically the condition you get when you're overweight. So if you're overweight or if you're obese, chances are you're suffering from the metabolic syndrome, and that puts you at increased risk. And people who are nearsighted are at increased risk for nuclear cataracts. And the genes can put you at risk. So if you have a history of cataracts in the family, yeah, you're probably going to get a cataract. And depending on the age of the other individuals in your family, that's going to tell you somewhat about your future, something about your future. And you can also find that congenital cataracts, they're probably 50% related to certain genetic abnormalities. And if we look at medicines, we find that certain kind of medicines are associated with cataracts. So if you're taking cortisone or prednisone, taking it because you have rheumatoid arthritis or because you have lupus or because you have some kind of allergic reactions, and you take the cortisone, that increases the risk of the posterior subcapsular cataract. Or if you have a psychiatric abnormality, you have schizophrenia, you're taking the phenothiazines, maybe because you have bipolar disorder or depression, that puts you at increased risk. Certain of the cancer chemotherapies can put you at increased risk. The miotics, the drugs that shrink the pupil, can put you at increased risk. Amiodarone, that's used for arrhythmias, can put you at increased risk. And we think that there's a possibility, an arguable possibility, that the statin drugs might put you at increased risk. And if you spend a lot of time outdoors, ultraviolet light puts you at increased risk. Wear sunglasses. If you have chronic uveitis, inflammation in the eye, that can cause increased risk. And there's a condition that also becomes increasingly common as we grow older, and it's known as the pseudoexfoliation syndrome. And pseudoexfoliation is basically the same thing as having dandruff. So instead of having the dandruff on your scalp and in your beard area, you have it inside your eye. That's the pseudoexfoliation syndrome. Increases the risk, also increases the risk of certain types of glaucoma. We have eye surgery that can increase your risk, and blunt trauma to the eye area can increase the risk. It increases the likelihood that there's going to be damage to the lens itself. And if you have penetrating trauma to the eye, and that penetrating trauma opens up the capsule, that allows water to rush in. And when that happens, then as an aftermath, it speeds up the process of your developing a cataract. We know that microwave radiation, that increases the risk because it causes some deterioration or degeneration or denaturation of some of the proteins inside the eye. And we know that the skin and the lens of the eye share a similar embryologic origin. So it's not unexpected that certain skin conditions are associated with increased incidence of cataract. So for instance, atopic dermatitis, childhood eczema, or a special kind of genetic dryness of the skin. We call it genetic ichthyosis. That's associated. If you smoke cigarettes, that increases your risk of nuclear cataracts by twofold. It doubles the risk, but it triples the risk of posterior subcapsular cataract. If you have low levels of vitamin C inside the bloodstream, that increases your risk, but don't go out and buy the supplements because the supplements don't seem to do any good. You have to eat the food. You have to eat the oranges and everything else in order to get the benefit. Well, if we talk about nuclear sclerosis, that's by far the most common. And with the hardening and the sclerosis that occurs over the course of the years, the lens becomes, unfortunately, white. Sometimes it becomes brown. We call it brunescent cataract if it becomes brown. Early on, when a person develops a nuclear sclerosis type of a cataract, if a person was farsighted, then all of a sudden the person notices that to read the newspaper, don't need glasses anymore. So that's what we call the second sight, but unfortunately as the cataract continues to get worse, you lose that. Then we have the cortical cataract, that's on the outside portion, and unfortunately over a period of time, that outer layer can become opaque, and we have fissuring of the lens. And when we have fissuring of the cortical portion of the lens, that leads to some glare, scattering of the light. Then we have the posterior subcapsular cataract. That's when it becomes cloudy at the back part of the eye that's adjacent to the capsule. And even though it's a relatively small area, that's where the lens seems to focus the light, or it's from where the lens focuses the light, and that leads to a disproportionate impact. But most people have multiple varieties of cataract. Now we have other kinds of cataracts too. So it's not just the age-related cataract, but we have congenital cataracts that are present at birth. We have infantile cataracts that develop in the first year of life, and pediatric cataracts develop in childhood. Could be on one side, or both eyes can be involved. A third of the time it's inherited, a third of the time we don't know the cause, a third of the time associated with multisystemic diseases or other eye abnormalities. And we can talk about cataracts as being hypermature. Typically we have some liquefaction of the cortex and the nucleus seems to drop to the bottom, or we talk about a mature cataract where the protein is all opaque, it's all thickened, can't even look to see what's in the back part of the eye. Again, both of those can either be white or brown. Then we can have an immature cataract. An immature cataract is where some of the proteins are white and some of them are still relatively clear. And then we have the incipient cataracts. Incipient cataracts, where the eye professional looking inside the eye with a slit lamp can see the problem, but you are totally unaware of it being present. Well, what kind of symptoms do you get with cataracts? With cataracts, you develop some loss of visual acuity. You can have some blurred vision. Sometimes it can affect your activities of daily living, so you can't read or you can't drive or you can't recognize people's faces. You have glare and halo from lights, especially with the posterior subcapsular cataract and the cortical cataract more so than the nuclear cataract. You can have colored halos around objects. You can have problems because of the light. The headlights cause disabling glare, faded color. Everything seems to be somewhat blurred or hazy. You can actually even have double vision inside one eye. It can't be corrected by changing eyeglasses. You can have trouble with bright lights, lamps or sunlight or headlights. They can seem much too bright. You can have difficult time seeing at night. Cataracts can increase the risk of falling, and then when people can't see well, that can increase the likelihood of suffering from depression. Frequently have to change the eyeglasses because the prescription seems to change, varies with the type of cataract, but we know that the nuclear cataract, as I mentioned, is associated with now you're being able to see near objects much better. Well, the posterior subcapsular cataract, that tends to affect the near vision and makes you see distant somewhat more better. If we talk about the treatment for cataracts, well, it seems that surgery is one of the most cost-effective things that we have in medicine nowadays. You can remove the cataract and replace it with an intraocular lens relatively easily and with relatively few side effects. The indications are when you have difficulty seeing and when the risks of the surgery are not as important as the benefits that you might obtain if you can see more clearly. Now, we don't do the surgery to prevent glaucoma, but sometimes we do the surgery so that we can see the back part of the eye because there's a problem, if a person has a cataract, of being able to see what's happening in the retina. And you know, as you get older, that you can have an increased problem with retina, retinal detachment, and a variety of other problems that you wouldn't notice, wouldn't be able to see unless you could look through the eye. Well, there are some other methods that we can use with beta ultrasound scans, but different story. So cataract surgery can trace its roots to the 5th century BC in India. It was also performed about 29 AD in Rome. We've progressed in our abilities, certainly the ability to put intraocular lens in place, but it's the same general concept. We can classify the opacities in the lens, that's relatively standard. We can check your visual status. And actually, the visual status is the thing that should most account for when you have the surgery. Preoperatively, well, do you need a medical evaluation? Do you have to have your electrocardiogram and a chest x-ray and okay from your internist? It's frequently done, but really it's done without any good evidence. So no, you don't need that. Do you need to stop your anticoagulant? Most people say no. If you happen to be taking a medicine to help you urinate, if you're an older gentleman and you have some prostate problems, you might be taking a drug like Flomax that might lead to the intraocular floppy iris syndrome. That's okay. You just tell the doctor what medicines you're taking, and that might change the surgical technique a little bit, but basically no problem at all. Well, in the pre-op examination, check the visual function, check to make sure everything else is okay with the eye. And then in selected patients, if the cataract is very thick, maybe do that beta ultrasound scan to check the back portion of the eye. But it's during the assessment that the doctor determines what particular strength intraocular lens is going to be used. What kind of anesthetic does the person use? Well, it all depends. Depends. In the pediatric population, still, for most children, still general anesthesia. But in adults, either an injection behind the eye called retrobulbar anesthesia. But That tends not to be done as much as the peribulbar anesthesia, safer because the needles don't go behind the eye. Or sometimes just an injection under the conjunctiva, or sometimes even in the space between the capsule and the sclera, or sometimes even just with some topical anesthesia. What's the surgery require? Well, it doesn't require a ripened cataract. That was a term that was popular some time ago. Basically, a small incision, often just 2 or 3 millimeters, basically the width of a dime or a nickel. It's performed right at the junction of the cornea and the sclera of the eye. Go into the area where the lens is, open the capsule. Typically now we do phacoemulsification, where some ultrasound liquefaction of the lens takes place. In the older days, in other countries, still removed manually, and then the lens is implanted, and then once everything is done, maybe a little bit of saline is injected into the sclera of the eye so that we have some swelling, so don't even need a stitch. The older operation, where the surgical scar was up to 1/4 to 1/2 inch in length, well, that required some stitches. The intraocular lens itself is polymethacrylate or silicone or acrylic. You can get a monofocal lens, or it could correct astigmatism with what's known as the toric lens, or could correct for the presbyopia. You could get a bifocal or a trifocal. Sometimes the laser is involved to help speed the surgery and take care of some of the common sorts of procedures that are necessary to get to the phacoemulsion stage. They argue whether that's really necessary, whether the cost-benefit ratio for the laser is appropriate postoperatively. And the operation takes very few moments postoperatively. Shouldn't strain for a while. Typically, you're given some eye drops. Use the eye drops, either an antibiotic or a steroid or a non-steroidal anti-inflammatory medication. Use it for a week or so. All depends on the doctor, all depends on the particular circumstances. Well, you should be followed by the doctor, check the next day or within the first week, and then maybe a month later. Sometimes the vision changes for up to the first month. Complications, relatively infrequent. Complications could be the intraoperative complications, or it could be either early or late postoperative complications. Sometimes there's retained lens fragments inside the eye. That can cause problems. Or sometimes there's edema of the macula. We call it cystoid macular edema, especially in people who've had a history of that or have a history of diabetes. Sometimes there's a problem with the vitreous or the retina, or sometimes there's infection inside the eye. A lot of people complain for a very short period of time of some glare or some light streaking or some halo effect or some general sensitivity to light or some lines that seem to be in the periphery. Tends to go away relatively quickly. One of the most common complications is posterior capsular opacification. So once the lens is removed, the capsule is not removed. And sometimes some of the fibers of the lens seem to adhere to the capsule. And then at some point in time after the surgery, 12% at a year, about 20% at 3 years, about 25% at 5 years, sometimes there's some opacification. And you say, oh my gosh, my cataract is back. No, it isn't. It's just that you have the posterior structure in the capsule has now become opaque. Laser therapy, the neodymium laser, just takes care of that very quickly. The symptoms that you would have that would give you the idea that you have the opacification, you have decrease in your visual acuity, you have blurred vision, sometimes glare, light scattering, same kind of things that you have with a regular cataract. But that laser therapy is very quick in-office procedure. Go back home, everything is okay. Sometimes infections do occur. Now, the infections are less than 1/10 of 1%. And For the most part, again, people who are diabetic are at greater risk. If the incision is done not at the junction of the cornea and the sclera, but if it's done in the clear cornea, that seems to increase the risk. There's a poor prognosis if the bacteria involved are other than the typical staph epidermidis, the coagulative staph, or if you had poor visual acuity to begin with, or you're older, or there's actual pus that you can see. We call it hypopyon. If you have pus that you see just looking into the eye, then that suggests there's going to be a problem. The cystoid macular edema, that's not an uncommon problem, anywhere between 1 and 10%. Most of the time that just calms down over a very short period of time, oftentimes with some topical steroids or some topical anti-inflammatory drugs. You delay the second surgery because of the potential for infection. So instead of having both eyes done at once, most people say, well, let's wait a while in between the surgeries. And if we do that, then we've reduced the likelihood of having a problem in 2 eyes. Can you prevent cataracts? Yeah, you really can. If you wear sunglasses, you wear a wide-brimmed hat, you avoid excesses of alcohol and tobacco. What about the vitamin supplements? What about having a diet that's got all sorts of these pills that are being sold nowadays? The evidence that they really prevent any problem is very, very minimal. So no, we don't think any of that stuff works. So that's basically the story of cataracts. Cataracts, age-related process for the overwhelming majority of people. They seem to be associated with the overall aging of the body. So that's basically the same thing that's happening inside your lungs and your heart and your kidney or your liver. So the better you take care of your eyes, hopefully, the longer and the healthier you'll live. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so that you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.